It's just good evening, everyone. Today it is the fifth lecture in the GAPIO series, GAPIO Physiotherapy International Lecture Series on non-traumatic shoulder pain. So, a very, very warm welcome to all the member of audience for the webinar on non-traumatic shoulder pain, which is the fifth in the series under this GAPIO Physiotherapy International Lecture Series. And what GAPIO is, Global Association of Physicians of Indian Origin. It is a non-profit organization established in 2011 by Padma Vibhushan Dr. Pratap C. Reddy, Chairman of Apollo Hospitals Group. He is the founder president of GAPIO with a vision of improving healthcare worldwide, with the aim to bring together healthcare professionals of Indian origin in the world on one platform. Through these webinars, our endeavor is to bring the latest advances in the field to fraternity globally. And I hope we'll have a global audience with us. So it is good evening from India. It is good afternoon for Dr. Hemant and many others joining from there and various parts of the world. Somewhere it is good morning and somewhere is it late evening in Australia. We also have Dr. Sushil Jain, who just takes care of the whole GAPIO work, which we pitch in as physio team with him. So we welcome you, Dr. Sushil Jain. We have other speakers also with us. So I'll just take it through. We all very well know today we are going to talk of shoulder, and I believe it is a matter of concern with everybody. So though this joint is complex, but I hope it's not complicated. So let's all really hear from the stalwarts that what all shoulder complex has in store for us. So now I would like to invite our keynote speaker, Dr. Bhavna Mhatre. She is with rich 40 years of experience in the field. She is PhD guide and she is member of Institutional Ethics Committee in State GS Medical College, Mumbai. She is retired professor in physiotherapy and HOD in musculoskeletal area and a resource faculty. I welcome you, ma'am, to share your experiences over the time, how you have seen the shoulder being assessed, being treated, and how it has really transformed into where we'll have our surgical expert also with us and other people all talking about it. So over to you, Dr. Bhavna Mhatre.
Thank you, Dr. Seema, for your kind words. Before I begin, I definitely want to thank Dr. Seema and all the EC members of Global Association of Physicians of Indian Origin for inviting me to share with my experience with all the stalwarts whom we are all waiting to listen. So as Dr. Seema said, that shoulder is a complex joint and the complexity of the shoulder is always challenging. And that is what, it has been very dear to me. I still remember the days when I graduated, we used to give passive movements. And I don't know, Seema, if you were also during that era, we were called as physio-terrorist, physio-massagist, because of this, to a level that we have come today as independent decision makers with our physical therapy diagnosis. And all this I owe to our teachers and all those who have contributed in the growth of our profession and the institute. Especially, I would like to mention Professor late Shahani sir, Professor Dastur Madam Kapadia of our institute, Bellary Madam, even Mokashi sir, all the stalwarts who improved our education standards and hence the growth of our profession. So I still remember if the range was restricted, all that we did was joint mobility exercises, stretches and strengthening without understanding. The exercise were prescribed and we used a lot of electrotherapy. The orthopedics, excuse me sir for this, but the orthopedic surgeons used to dictate treatments. They used to write shortwave diathermy, ultrasound, this exercise to be given. And I still remember going and convincing the orthopedic surgeons that we cannot give shortwave diathermy because the patient, though he has a shoulder pain, he is diabetic, he's hypertensive, so he's contraindicated. So, we've gone through all these things to now they write physical therapy and sense. I'm sure you also must be having the same experience. So we used to give exercises thinking glenohumeral joint is the shoulder joint and scapula is a separate. Sternoclavicular, acromioclavicular, though we learned in anatomy, 3 anatomical joints, though functional joints, the application was not there. We never had textbooks. So everything that we learned was on the phone. But as we got introduced to the new topics, manual therapy came into existence, joint mobilization, soft tissue mobilization, and the manual therapy assessment techniques, our diagnosis became better. So we started finding the structural cause for the functional impairment. Like if the external rotation is restricted, initially we used to give external rotation exercises, passive movements, active movements, whatever to improve. Now we try to find out what is the cause for that external rotation. Is it the scapulothoracic motion that is affecting? Is the scapula alignment? Is it the external rotator weakness? Is it the anterior capsule which has become tight and restricted? So we try to find the structural source, and then every structure has a treatment, right? So the interventions are also based on the aspect. We try to do the alignment. If the scapula is anteriorly tilted, is it tilted because of the serratus anterior weakness, or is it lower trapezius, middle trapezius, or is it the thoracic spine which is already into a kyphotic posture? So came introduction of the thoracic spine also into our treatment. When the thoracic spine came, the alignment of the whole body came into existence. So shoulder is not just treated now as, glenohumeral exercise mobilizations, but there is so much of understanding as our knowledge of anatomy, biomechanics, and neurophysiology is the basis of our treatment techniques. And with that introduction and understanding better, I'm sure we have become now more diagnosis. Our physical therapy diagnosis is with respect to the movement system impairments and not the physical therapy condition as such. So that is one of the things that I would mention. And every exercise is now, I think I really dream when all physical therapists will start prescribing exercises as a medicine. Every exercise has an indication, it has a contraindication, and it has a side effects. Like our times, we used to strengthen rhomboids. Okay, we used to think it is strengthened, but now with a better understanding, we know that rhomboids become overactive. And when we give strengthening, strong contraction and relaxation, I think that released the muscle, rather it gave results with whatever, but this thing was to strengthen. Similarly, shrugs, which we give for upper trapezius and levator scap. But basically it is not strengthening. We are inhibiting this overactive muscles so that they become better. So if you diagnose the structure, there is a specific exercise for it, and it will definitely help. Like stretching, we used to give stretching left, right, and center. But now we are able to differentiate whether it is a connective tissue which has gone into an adaptive shortening, or is it an overactivity of the muscle? And hence the treatment techniques are different. So there's a lot of advancement that has grown. And I'm really happy that we are, into this field with so much of our knowledge being shared, and we have earned a lot of respect. As you said, Dr. Tandon believes in multidisciplinary. So, I mean, we have taken a long leap onto this, and I think without wasting a lot of time, I would, even I'm waiting to hear from all the experts about the recent advances. We have a kinetic control also. So, we've learned also to activate a particular muscle, activation of these muscles. So a lot of things have changed. Neural tissue tension, we have started upper limb tension test. And so we were all exposed in the late 80s and 90s as all these techniques came international on an international global board. Our teachers introduced here also in Mumbai. So, so our syllabus also grew with respect to with global standards. So though shoulder joint is complex, I really, it is challenging because it's a complexities are there, and it's challenging. And let us hear from the stalwarts today of subacromial pain syndrome. The contextual factors, simple things like correction of getting up from the chair. If you get up from the chair with the support, especially in the elderly, there is decrease in the space, subacromial space. So that whatever you treat the patient, and if you do not correct this contextual factor, then again, the patient comes to us. So the introduction of ICF in our curriculum, where contextual factors are given importance apart from the pathophysiological processes which the doctors treat. We don't treat the pathophysiology. So that understanding is there now, that we treat impairments of the movement system and the contextual factors giving rise to this thing. Okay. Thank you. Thank you so much.
Thank you so much, Dr. Bhavna, for setting the tone. I believe our audience are definitely with you, definitely getting the point that we physiotherapists, it's the time that now exercise comes as exercise as medicine. And we are all here together to listen from everybody that how this shoulder complex can really be made simple for patients to get their treatment better. So thank you so very much for setting the tone. Now, without taking much time, I'll introduce our today's speaker. And we have three prominent champions from the medical and physiotherapy field to discuss this important topic, which has musculoskeletal concern in all age groups, which is non-traumatic shoulder pain. So they are also going to shed light on the latest advances to help ignite a healthy discourse for clinicians and academicians, ultimately to think that how we can expand our scope of practice and improve patient care. So now I invite Dr. Hemant Juneja, who's our first speaker for this webinar, to speak on the topic Understanding Subacromial Pain Syndrome, Physiotherapy Perspective. Regarding Dr. Hemant, I would like to introduce him. He's Associate Professor at the Physiotherapy Education Center of Health and Rehabilitation, University College Absalon, Denmark. He has many national and international presentations and publications to his credit. And his core research area is in shoulder and knee injuries and its rehabilitation. He is reviewer of many journals and member of writing group for physiotherapists in emergency room in Denmark. So without taking much time, I invite you, Dr. Hemant, to please take us through that what the European guidelines and what is the physiotherapist perspective in understanding subacromial shoulder pain syndrome.
Thank you very much, Dr. Seema, for such a nice introduction and welcome. First of all, I would like to thank you and also Dr. Sushil, Dr. Havintan, and it's an honor to be speaking on this multidisciplinary platform. It's always a pleasure. I worked in India for many years, almost 13 years there before I went there. So it's always interesting how Dr. Bhavna just mentioned about the very complex relationship that orthopedic surgeons and physiotherapists share, and which is actually very tricky. But at the same time, before starting my lecture, I also maybe just extending that part, would like to mention that actually it is a very, very important sort of a relationship that we must share at a professional platform, because, for example, here in Denmark, I can tell you that most hospitals, they have a morning conference where physiotherapists and orthopedic surgeons are sitting together and discussing certain patients. These discussions even happen before the surgery sometimes, that are we sure we're operating this patient? And I think that is such a big learning for us, even though I'm teacher, researcher, but I still see patients, which is very nice. So I think those sort of developments are also very important, because I agree with Dr. Bhavna saying that, okay, it was being dictated, but you see, there needs to be understanding between two type of professionals for those sort of issues to be resolved. So I think that is a very important part. But let me start my lecture by sharing my slides. So the essence of my talk is basically subacromial pain syndrome, and I'll the agenda here also is that why am I calling it subacromial pain syndrome and why we didn't call it subacromial impingement syndrome. That's a part of this talk, and I'm going to be focusing a little bit on the evidence part more from here, extending from the talk that Dr. Bhavna just introduced us to about structure-specific diagnose. So this talk is probably going to extend that structure-specific, stretch it a little bit more towards structure-specific versus function-specific and assessment. So just a little historical perspective about the subacromial impingement syndrome, which is almost a 50-year-old concept now. And at that point of time, it was mentioned as a supraspinatus tendon, long head of biceps, and subacromial bursa that were primarily involved in the description, the original description of Charles Neer, who gave this term. But the interesting part is, even in his own study in '83, he wrote that he believed 95% of the tears of the rotator cuff are caused by impingement. And I highlight the word believed because it's quite a dangerous word in healthcare, that I believe. So that in the current terms, that can be challenged. And these three structures, as you see. So of course, when you define something like an impingement, that something is getting pressed, the logical treatment at that time became acromioplasty, right? So you sort of make a subacromial decompression based on the assumption that everything pain under the acromion or around this anterolateral region of the shoulder was sort of impingement, right? So that's why this was the most logical treatment. Now, coming to some research around 2018 and also around 2016, which I've not included, but this study, I mean, they conducted a decompression compared with the placebo on 313 patients actually. And placebo was just a sham arthroscopy without any procedure inside. And they showed that surgical decompression appeared to have no extra benefit over simple arthroscopy, right? Similarly, in 2019, a study which was done on many patients again said subacromial decompression does not provide clinically important benefits in pain, function, and health-related quality of life over when compared to. So what happened over the years? One of the biggest things that happened was that in order to identify structures of what is giving you pain, we have over 120 special tests in shoulder. And that is quite amazing. And that is why when we say, is it complex, complicated, whatever word we use, but for a clinician, it is always complicated on which test to choose, which tests are best, which tests have a good sensitivity and specificity as a combination to rule in or rule out a specific shoulder problem. So that way it gets very, very complicated for the practicing both physiotherapists and I believe physicians, orthopedic surgeons as well, because I'm going to come to that point why it's difficult to sort of depend 100% on these tests. And of course, when it comes to impingement, we said about these 5 tests became very popular as a cluster, that if you did those 5 tests together, and this is about a 10-year-old story, that we said that, okay, if you combine these 5 tests, they are very sensitive. And if you combine this, 75% of patients with subacromial impingement syndrome, SIS, have minimum 3 out of 5 tests positive, these people. That was decent sensitivity, I would say. But the problem was they had good sensitivity, but poor specificity, which means when we say poor specificity means poor ability to identify the specific pain generator. So they could be positive in many sort of pathologies, but they were not specific enough to be to identify the correct structure as a pain generator. And that is the problem with many of the shoulder tests, clinical tests. Not only that, there is also limited support for biomechanics of the compression, that we say that subacromial structures get compressed. There is research challenging this notion of saying that, well, I can apologize for saying notion, but yes, there was research to prove this before. But this has been challenged a lot. And now there is research to show that by 90 degrees of humerothoracic elevation or 60 degrees of glenohumeral elevation, the supraspinatus actually has already cleared the coracoacromial arch. So this whole idea of 60 to 120 is being challenged now as a painful arc. There is research to show it. So that means that impingement is multifactorial. It is not necessarily related to actual mechanical impingement. that we believe that it is mechanical impingement. And there is, again, decent amount of research to show this, that it is not probably impingement. In addition to that, now coming to this whole idea, well, if it's not impingement, should we call it impingement? Or if the impingement can be challenged. So there's this study from 2011 that this was an ultrasound study on 51 shoulders on normal subjects, asymptomatic subjects between 40 and 70 years of age. They showed that 78% of these 51 had subacromial subdeltoid bursal thickening. 65% had AC joint OA, osteoarthritis, supraspinatus tendinosis in almost 40% people. So you can see that a lot of normal shoulders. I know that the numbers are not very big in this study, but this is just one of them. There's many such studies which show that normal changes in asymptomatic shoulders are present. And that makes our life even more difficult when we read a particular radiological investigation and label it as a cause of pain. You see that you have this, so probably you have this. That becomes difficult, and that's why we say all radiological investigations say please correlate clinically, right? When we do that, we are challenged with the problem of clinical tests. So what we're trying to say is structure. Let's say this partial bursal sided tear in a supraspinatus that you see in this red circle is not equal to pain always, right? And we know that more and more because pain itself is multifactorial, right? Pain is not only biological. We talk about biopsychosocial factors a lot, saying that pain is a subjective experience. Somebody who's training for the shoulder every day is very motivated, can suddenly feel a lot of pain because he cannot do his shoulder presses. But somebody who's challenged in the family can perceive a lot of pain because there's a psychosocial component into it. Those are areas also to be looked into. So if it is not impingement, that is why the terminology is being recommended as subacromial pain syndrome. Don't call it sub-impingement. And this includes actual impingement, if you can, subacromial burst series, calcific tendinitis. These are some terms. But when you go into the details, which I don't have here on the slides, but for example, they say do not include frozen shoulders or capsular lesions into this, or labral tears into this. So there is clear-cut definitions for this. So again, going further from Dr. Bhavna's discussion about SAPS, or now I'll call it SAPS from here. SAPS simply implies functional impairments. They're not. It doesn't make assumptions about what structure is it, but because it's difficult to find out what structure is it through clinical tests. But the problem is, if we call it SAPS, it's like calling unspecific low back pain, right? Which is a very popular diagnosis now, that you have an unspecific low back pain. But it's an easy diagnosis to hide behind. When we tell people, it's like saying, I can't find the cause, so you have an unspecific low back pain. That's a little poor argument sometimes. So it is challenging this term, because it's easy for anybody to say subacromial pain syndrome. We don't know what is it, right? So, but the suggestions as of now are that you can categorize these SAPS patients into some categories. You could have SAPS with overuse and overload in overload patients, right? For example, a swimmer's shoulder who's going 10,000 revolutions on an average day, high volume sports. So that could be one area to look into. Do you have a patient which has an overuse and overload history, or do you have a patient with SAPS with muscle performance deficits? And this, I believe, everybody sitting here today and joining here knows about that. We know scapular thoracic couples and posture and scapular motor control deficits. So it's not only about strength, but it's about the coordination of the muscle, right? That if we want force couples to work together, if upper traps and lower serratus anterior, they don't work together. So we're talking of a coordination. It's no point keep strengthening one of them. Nothing will happen, because they need to work together. We have a symmetry in the. Then we have people with movement coordination deficits. We know this one as well from different type of scapular dyskinesia and scapular positions. But we know again, challenging the structural part and the positional postural part, we know from a lot of young active sports persons where scapular winging of different types is just a normal adaptation and nothing more than that. They are completely asymptomatic. They have developed it. There are no prospective studies which have proved that people who have a particular type of winging, the different types we know, if they have different type of winging, can lead to an increased chance of shoulder pain or injury. There are no studies like that. So I'm just saying we need to take this structural thing and postural thing and winging thing with a pinch of salt here, right? We know also with tightness that pectoralis minor tightness or thoracic kyphosis. So that's the next category of saying subacromial pain with this prominent features of tightness or a bad thoracic curve, tightness of internal rotators, because we know that when scapula is anteriorly tipped and they could have, people are more prone to it. But again, it's so that is one suggestion to categorize your patients into different categories. I'll just skip this one slide. Going to treatment recommendations, it's an overall, I'm not going into very specific, that's probably not the agenda here today, but evidence-based guidelines recommend non-operative, including exercise therapy as the first line of treatment. And I'm talking about guidelines from UK and also Denmark. And some of the studies, the remaining are from Holland. And surgery should only be considered when non-operative care fails is the current recommendation, right? And this exercise therapy is approximately 12 weeks, which is mentioned in some guidelines, Danish as well as UK. But non-operative care also includes corticosteroid injections, laser, acupuncture, soft tissue, mobilization. Of course, we know that the evidence in electrotherapy is fairly low-level evidence. But when I say low-level evidence, it doesn't mean low-level evidence also means lack of research, right? So it's just an indication that we need more research to prove our points of using lasers, ultrasounds, TENS, and all those things that physiotherapists use. And diagnostic imaging is often recommended, at least I know from here as well, that diagnostic imaging is not something done right away. People wait, they get an exercise program. And but also I understand that when I'm talking to my fellow colleagues from India, we have a different context also in the European region in terms of economy, because the state wants to save as much as possible. It's a pooled money, you see, the healthcare is coming from the people's taxes. So that could be the economical concern here. And there is decent evidence to show that patients who do strengthening exercises have a significantly better chance of improvement than patients who conduct only posture or scapular exercises. That is one take-home message for me. Strengthening exercises in recent research have shown better effects than if you compare it, because I'm going to talk about why I'm saying posture or scapular setting. We are not saying that other exercises have a damaging effect. I mean, sorry about this don't here. I think it's a grammatical error from my side. But what I mean is that we're not saying that posture and scapular setting is not needed. But we are what this research suggests, and is also other research that suggests, problem is that if you make an exercise program with scapular focus, with posture focus, with stretching focus, and some strengthening focus, what happens in that plethora of exercises, the focus on strengthening reduces drastically. So that is the agenda where we say, can you categorize your patients in a particular group? Is it mobility deficit? Is it strength deficit? What is it? If we talk about function. So your exercise could be more focused there. And this study has been actually done by one of my colleagues in Denmark. He's an orthopedic surgeon also, and some PhD students did it together. And it's quite popular. All the references that I'm giving you are on my slides. And at the bottom of every slide, you have the reference for what I'm talking out from, right? So if we say, if this is the case, strengthening exercises is the most beneficial that has been shown, it aligns with the current understanding that subacromial pain is mainly a muscle tendon disorder, right? Because if that is the case, if strengthening is what, and not a consequence of mechanical impingement to structural bony abnormalities. And this discussion was way back in 2013, that impingement is not impingement, as you see below, right? So we do have compliance issues. That this is a recent study done again in Denmark, where they found that more than half of the patients, if you recommend a program, they don't comply with it, right? More than half. But at least 87% started with, this was a survey done. So 87% started with some or the other form of subacromial pain exercises. And 40% of the patients who underwent surgery had not completed 12 weeks with exercise therapy. So, but this was quite surprising for the researchers there, because they thought it's a striking contrast to the national clinical guidelines in Denmark, right? Because they should have done it before they got operated. Supervised, should the exercise be supervised or non-supervised? Science says there is no difference in pain and function, whether you have supervised or non-supervised, which is, I know, not very nice to hear for people who would be thinking, what about my bread and butter, if they can do the exercise on their own? But that's not the case. When we say non-supervised, we still say supervision means regular intervals. As a non-supervised means that you do your exercises, but we make your programs and we guide you how we progress. So it's a different approach on, and I think it's all the more relevant in India, where people come from smaller towns to metropolitans to find good solutions, and with a thinking that metropolitan cities in India have better healthcare facilities, right? So it could be even more relevant thinking like this with this form of evidence. And of course, so I'm not going into the evidence saying, okay, what form of scapular exercises, rotator cuff, this we all are experts in, people sitting out here, but rotator cuff, scapular muscles, stabilizing exercise are some of the mainstay of this treatment. What about non-responders, people who don't respond with 12 weeks? Many of them are getting corticosteroids, and of course, surgical interventions for specific structures, if identified. But yeah. Taking the last one, if I was to sum up this, I would say continued research is needed, especially for type, dose, and duration. We have a big problem with that. What type of exercise is good for which muscle? How many sets? How many repetitions? How long before I can expect an effect? Those are difficult questions to answer, right? People often ask us these questions. We don't have a realistic answer to this. If physiotherapists are performing manual therapy, remember that evidence suggests effects are only short term when we talk about manual therapy. So if you say, I can make a little harsh sentence here, that do not continue manual therapy for very long periods with these patients. It's not useful. Science is not showing this. Electrotherapy, we've told you, generally low level evidence, but recently a Dutch guideline recommended very highly about shockwave for calcific tendinitis. So if you find a calcific, they recommend that it has decent evidence for it. So I end by saying the evidence for the use of exercise therapy is something that is consistent all over. Right? Thank you very much for giving me this opportunity, and I believe I will stop sharing, and then of course I'm available for the question and answers now or later. Thank you.
Thank you, Dr. Hemant, for a wonderful talk. And I believe all of us well resonate with you that yes, exercise, and now the evidence also says. So what you spoke about, I believe most of the physiotherapists who are on board with us will agree that exercises do make a difference, and quite a bit of difference. But as you rightly put, that 40% of people, even after surgery, in your area where it is freely available to them, also never joined for their sessions. So that also holds very true for the population to really understand that how important it is. And without taking much long, thank you so much once again. I would now invite our next speaker, who's an eminent orthopedic surgeon here, Dr. Havin Tandon, who's going to talk about understanding this subacromial pain through surgeon's view. And Dr. Havin Tandon, is a senior consultant of in the Department of Orthopedics in Indraprastha Apollo Hospital since 1999. And apart from being very eminent orthopedic surgeon for robotic navigated replacement surgery and arthroscopic procedures, he has a deep flair for academics. He is a teaching faculty at Apollo Delhi for FNB arthroplasty and DNB orthopedic students. And I would like to definitely share that he believes a lot in multidisciplinary care, as we were discussing before we started the session. And he has been principal investigator for various clinical trials and has published many articles in indexed international orthopedic journals. So without taking much between you and him, I would request Dr. Havin Tandon to kindly show us the way through a surgeon's perspective.
Thank you so much, Seema ji. I hope I'm audible to everybody. Right. So after a lovely talk by Hemant and lovely words by Bhavna ji, I'll just walk you through. Some slides will be a repetition, so please don't mind. But where I'm coming from is the void which most of the orthopedic surgeons face when they are managing the shoulder problems. Like Hemant beautifully showed, there is a huge dropout before they have actually reached a clinical setting. Most of the patients are doing things all by themselves, and there are lots of myths and issues which are there. Life is not so different, let it be Denmark, England, or India. The awareness, even amongst orthopedic surgeons, is, and many physiotherapists, huge voids are there. Even in my understanding, I'm learning each time I come to such platforms. What Hemant showed, there are so many lovely points which I've made a note of, and definitely it will help my practice. So without any much delay, I'll just run through my slides. We all know shoulder is the joint, the complex joint that we all have massive range of movement. You all know about this. And the common public perception is a shoulder problem means frozen shoulder. Gynecologists, other orthopedic surgeons, everybody feels a shoulder problem is a frozen shoulder, and the treatment is 8 or 9 months of rigorous, painful therapy, you'll get fine, right? But the differential diagnosis of the shoulder problem is huge. So many points of which we'll be discussing, only a couple of them. So the topic handed over to me by Seema ji is the surgeon's perspective. So I'll just go through quickly what I face. The shoulder cases in our OPD are almost now reaching second after the knee. Sometimes back pain patients were more, but now it's more after the knee. It peaks in the usual age groups of 40 to 60, but younger patients who are either recreational or professional athletes also come to us with shoulder issues. In my mind, a good history and a keen observation examination is the important points for making a diagnosis and for me to move forward. This is an important line. Some of my colleagues don't like this. Some orthopedic surgeons also are not aware about it. Why? Because we don't go through the basics of the shoulder, the knowledge that yes, this is a ball and socket joint, but it is working on a huge big ball based on a small bony part. Rest, everything is provided by multiple factors which provide, you all know this slide, seen from the front, seen from the back, but these muscles work in this closed space, as you all know, the coracoacromial arch, and anything which is getting crowded there, like Hemant beautifully pointed out, starts maybe to symptom level, maybe less than that. but the patients start getting disturbance in their basic routines of work as well as sleep. That is when they come to us. The medical causes, you all know, in India, we have a lot of diabetic patients. So my almost 40% chunk is coming from the poorly managed diabetics, which will have bursitis, which will have other things. And in case they have any structural compromise, those shoulders don't do well. We also have untreated or poorly treated AC osteoarthritis. That also, in my mind, is coming as another issue in India. Sports, yes, it is on the rise, but it is still less. We are getting more and more professionals who are having these problems because of their long hours in the particular, especially with use of MIS surgeries now. Like our laparoscopy team, the robotics team, the ophthalmologist, many of them are struggling with their shoulders because they have to keep their arms in a particular position for a long time. And then they start going into the cycle of events. Ultimately, I'll say it is a spectrum of the impingement or the subacromial pain syndrome, like Hemant said. We all know that we'll have patients with adhesive capsulitis who go through this cycle, and you can see they just cannot have fruitful movements. They have tried physio, they have tried other things, and that's when we are called in that it's not improving. This is how things look on the arthroscope. The picture on your left is the arthroscopic view of a normal shoulder. You can see it's glistening, perfect, soft white. And on the right, you can see the angry synovium, and I can't even sweep my arthroscope. It's that tight. We are religiously sending these patients for physio, sometimes doing interventions. I like to do an ultrasound guided steroid, not a blind technique steroid. And after that, still around, I'll say 12 to 16% of our patients don't improve. And they then are taken up for some surgical intervention like a release. Bursitis or tendonitis are typical like overuse issues. And then we move into the rotator cuff spectrum, which is having, like rightly said, a multi sort of dimensional issue. That is it bad musculature, posture, or actual structural impingement. But most of the times in India, patients who can afford have done their MRIs, a series of MRIs, and then we can study that, yes, the health of the critical zone of the tendon is slowly going out, and these patients will head towards maybe a partial going to a full thickness tear after maybe a trivial issue. I have a case which I'll show and share with all of you. You will then understand that. This is another important thing most of our patients we need to tell, that once they are more senior, their incidence of a cuff tear is higher. They might not be symptomatic. We have so many of our surgeon colleagues who we did our MRs and then we found out they had a full thickness tear and they were functioning near normal. It is only once their muscle wasting got slightly more progressed when they decompensated, and then it was a panic that they could not even lift up the lightest instrument, and then their function got majorly sort of hampered. So in management, as when it is my role, I again will highlight the history is important. What was the journey of this shoulder is important, and what interventions were done. Did they take proper good physical therapy? Was shots given? The shots were with ultrasound or otherwise, and then do a careful examination, not increasing the pain to the patient. I do my basic lab test in almost all of my cases. Start with X-ray. For the entire audience, I've brought few X-rays which will highlight the importance of X-ray, because we are seeing at Apollo, most of the patients walk in with MRs. They have already done MRs, and the MRs might be not done correctly, or done with a very, very low resolution machine. So then it becomes another problem for us to repeat the MR. It's a cost issue. Let it be Denmark, England, or India, somebody is paying. So that part is important. Look at this X-ray, 52-year-old lady complaining of pain. Majority of the, I'll say, attendees will say, this is a near normal shoulder, it's okay. Now I'll show you the simple X-ray, the Y view, and this was the problem staring at us. So this is not rocket science. This can be done in any tier 1, tier 2, tier 3 city anywhere in the world. So this, I brought it as an education. Please don't discount a good plain X-ray. It is important. And once you know that there's such a big, huge spur, obviously you will have your antennas out and you'll pay attention to. Sometimes patients come to us after one successful surgical procedure, and then they are in a hurry that I have a shoulder problem. Please immediately do something for me. We have patients who are foreigners. They are on medical visas, so their time is limited and they want quick succession issues. But you do the correct investigation and then you realize this patient also will need something for the shoulder in the form of arthroplasty. So investigations have to be chosen well, and that will happen if the history and examination have been taken properly. In my treatment protocol, I do it as a step sort of a approach that first I try and attempt pain relief with the lowest, simplest medication, activity modification, using of a lot of cold pack. Things don't settle down. Obviously, my physiotherapy colleagues step in and they work on all these areas to improve the range of motion as well as address some pain. Patients who are not settling down, like I said, I always like to use ultrasound for giving the steroid shots. We give interscalene blocks. I don't like to use manual sort of movement under anesthesia. I don't like to do that, manipulation under anesthesia. Instead, in case I feel this is not opening up, I'll do a controlled arthroscopic release. Those patients who need a decompression with a very bad bursa or a acromioplasty, in case there is a spur or a downward acromion, do it along. And we'll talk about the rotator cuff a little later. Like I showed in the MR, patients who have shoulder problem needing plasty are a different set. But in this entire treatment, my physiotherapy colleague is not just an adjuvant. They work with me pre-intervention, post-intervention, and give the final rehab to all my patients. In fact, we have seen that our post-op patients, we are having a better result when we call them and give them, after the period of initial post-op period, 5 or 10 sittings at our team department, and then the patient goes out and is in touch with us. We are getting a uniform good result by this approach, because I have to also work on the cost effectiveness, because not all patients are from Delhi. So regarding the RCT, the selection of the patient is important. I need to definitely go through all these points regarding my factors on how bad is the tear, and also be sure, because we are also getting many patients coming in late, sometimes in stage 2 upwards of fatty degeneration with a big retracted tear, and we have to say sorry. So rather than operating all cases, we have to be judicious that yes, these will work arthroscopically, the others won't. For some of the colleagues to see the MR pictures, this is how a partial thickness tear will look like, and a full thickness tear will look something like this. Once the tear is extending, the supraspinatus, you can see a lot of fluid. In the other slide, the subscapularis also had the tear, so there was a posterior and an anterosuperior deficit, and the dropout test in this patient is positive. And patients who come in late, we have patients who come in this stage and then they want wonders to be done. we have to hold our hand and give them the realistic picture, because such cases surgically with arthroscopic repair will definitely fail. If I have to choose surgery, these used to be the protocols. Open is totally out. In my practice, mini open is also out, because as you can see, this gives rise to a lot of additions. Whatever little deltoid is stripped, the physios cannot get it back. So in my practice, this is the sort of scar that we get, and this is recommended. We try and do all our cases arthroscopically. Some surgeons like to do it in beach chair position. Just to walk you through, P stands for the posterior portal through which we enter. My video, I've just put it so that you can follow the video which I'm going to show. These are the other portals that we make, and you match it with the line diagram which is below. We entered the scope from the posterior, and these are the other working portal. This is the view what we see in a normal shoulder. But those surgeons who like to do it in a lateral position, you have to orient yourself with 90 degrees turn, and this is how the look would be. So the steps when I have to do a rotator cuff repair would be a diagnostic quick assessment, release the interval, depending on requirement, do a tenotomy or a tenodesis, then go for first the subscap repair, clear the bursa so that I can see where I'm going to work regarding the cuff. All this is done through the posterior view portal. Then I change my portal to the lateral portal, and then I start the repair. It might be a single row or a double row. I've got a case for you guys to see. A radiologist who happened to be the head at our institution. This is his history of 6-month pain, did not seek any sort of care or intervention. He was the head of department, but still did not do the MR, did not do the X-ray. And then one day he had a slight jerk. He was a Sikh gentleman, could not tie the turban. And that is when he touched base with me, and he had a full drop arm positive. This is his MR, and this is the big, massive crescent tear. For my other colleagues, just for understanding, he had a tear of both the sub as well as the supraspinatus. So the steps that were done for his case, so that you can understand the video, I've just done an animation for you guys to understand. We first put the anchor, put the sutures, then we put anchors just at the junction of the cartilage to the footprint, put the sutures, tie the sliding knots. Once we slide the knot, the cuff automatically comes to place. I like to do a double row repair, by which we put lateral row and press down on these. So quickly, you'll see the steps. We are doing it in a lateral position. Left is your head, right is your foot. The top is the humeral head, down is the glenoid. We first saw that the subscap was fully torn, the biceps was not healthy, so a tenotomy and then a tenodesis was done for this. So this is the release of the biceps tendon, it just glides away. After the biceps tenotomy has been completed, we just assess how the subscap is looking. We lift it up where it should be attached, and that is the rotator interval where all that blood is coming out from, and the crescent you can see on the other side where the needle pointed. Holding the subscap so that we get a little orientation of the anatomy, we do a good release of the interval. All that synovitis as well as the scar tissue is removed. Then where the subscap has to be attached at the lesser tuberosity, that area is made raw. With the rasp, we get the bleeding bone, open that area. I like to use preferably a titanium suture anchor out there. You can see the anchor loaded to the driver going inside the bone. It was a big tear, so it's a double loaded with tight rope. We put it into the bone. You can see all the fat globules floating out, and that sutures you can see through the driver. The loading arm is removed. So now I have sutures directly going into the head. I take bites through the subscap. This is how we do it, and thread the threads out of the cannulas and make a sliding knot. We deliver the sliding knot so as to get the subscap absolutely back into its bed. So the viewing is happening from the posterior, and all that you are seeing is the anterior side. There is the knot going in, and you can see the entire subscap has lifted off to its near normal position. The threads are now divided and cut. At this junction, we see how mobile is my cuff. Can I bring it to its place? Now I go into the subacromial area, clear the bursa. The bursa is very, very angry. You can see it bleeds repeatedly. So we are working at the undersurface of the acromion. The white structure below is the cuff, over which was the bursa. We switch the camera to the lateral portal. Now you can see the entire joint end on. In the depth, you can see the glenoid. The humeral head is just near to the instrument where I'm working. And this crescent is the torn cuff. The remnants of the tear, we have to clear and prepare the bed for a good, strong repair. So you can see there is a huge amount of tissue which is on the tuberosity. So we'll just clear this off with a shaver. Once this is all cleared out, then with the burr, we decorticate very lightly the layer so that bleeding points can be seen clearly. You can see now this is nearly ready, and the articular junction, you can see at that spot, we'll start putting the anchors. So this is the driver pilot hole, and the anchor will be, I like to use a screw in at times when the bone is strong. It has graduated threadings, as you can see. So I get an extremely good hold into this bone. He was fairly active guy otherwise. So this is a double loaded anchor. So we put 3 of them. They are put below the level of the tuberosity, and then using the expressive, we take bites into the edges of the cuff at intervals carefully so as to get a good uniform pull back to its bed. Knots are again made outside through the cannulas. These are sliding knots. And when we tighten the sliding knots, they just press on the cuff bursal side and get it back in. Now the ends of the medial row, I like to put them in 2 lateral rows so that my lift off of the edge of the cuff tissue doesn't happen, and I get an extremely good construct. So this is you can see the threads are all coming, and the cuff end, you can't even see the tuberosity is fully covered. So the lateral low anchors are put, 2 of them, as you can see. This is the second one going in, and you can see the crisscross which is coming and pressing down at the leading edge of the torn cuff. Then the acromioplasty is done because there was a big spur in this case, as well as a lot of tissue around it. And then the final look you can see of this repair. So extremely good, satisfying result. And this is how it looks, and this is his function. He was kind enough to share this video. You can see full range of comfortable movement. He loves to do yoga, and you can see he has returned to his passion quite well. So to summarize, shoulder problems are significant in any society, and they are a cause of distress to the patient and a financial loss to the patient and the country. It needs good clinical examination and history taking, doing the indicated tests to identify the problem. Physiotherapy exercises are integral in the treatment of shoulder problems in my practice, and arthroscopy is a precise tool when used correctly for a rapid post-op recovery. So thank you so much.
Thank you, Dr. Chandan, for giving us such a overview of arthroscopy in the management. And I believe fellow colleagues will agree that yes, of course, when we work on that movement system impairment, and whenever we find, yes, there is certain requirement of arthroscopy, it helps us in our final rehabilitation and outcome. So definitely, thanks once again. And before taking much long, because I believe we are pretty exceeding our time, thank you once again. We would switch over quickly to our next speaker, Dr. Jamin H. Bhatt. He's going to talk about kinetic chain concerns in non-traumatic shoulder pain management. So to introduce Dr. Bhatt, he is a senior physiotherapist at ISRO Ahmedabad and a certified manual therapist with various international publications and chapters to his credit. He will share his expertise now. Before taking much time of everybody, I believe everybody is eager to hear you, Dr. Chairman. We have you on, so kindly take it.
Yeah, thank you so much. I hope I'm audible to everyone. Yes, fine. Okay, so we'll start our session regarding the kinetic chain. Okay, so it's visible.
Yeah, please put it to
Okay.
screen share.
So fine, previous two sirs gave us a very fantastic lecture regarding the shoulder impingement pain, as well as the orthopedic surgeon has very well explained about the surgical point of view. So I will take cover regarding the kinetic chain approach for the non-operative shoulder rehabilitation. Basically, whenever patient comes to our clinic and the kinetic chain terminology directly comes to our mind, shoulder should be rehabilitated from the kinetic chain approach. So what is the kinetic chain? It's a kinetic chain shoulder rehabilitation, which incorporates the kinetic link biomechanical model, and which is from proximal to distal and motor activation pattern with proprioceptive neuromuscular facilitation exercise technique. And
I mean, your slides are not moving.
No, sir. Just I'm explaining it. I'm not moving right now the slides.
Just give enlarged. You put the.
Is this not an enlarged view?
No. Please go on to that slide share.
I have kept on my slideshow as well. Your screen sharing. My screen sharing is paused.
What you can do is you can disconnect and log off and log in again. That might help.
Because my
If it's working at your end, then probably relog in will help.
my screen sharing is paused. That's why.
You can stop sharing the screen and restart sharing the screen. Give it a try.
Yeah.
Okay. Now,
Yes,
Now it
it's
is-
fine. It's fine.
okay, fine. So the kinetic chain approach we in shoulder rehabilitation, which incorporates the kinetic link biomechanical model and proximal to distal activation pattern, along with the proprioceptive neuromuscular facilitation exercise. And this approach should focus on a movement pattern rather than isolated muscle exercise. So whenever you have a patient with shoulder pain, stick to the kinetic chain approach, that will help you to improve the outcomes, because only 30% is energy transmitted from the shoulder joint, rest of the energy is transmitted from the lower limb itself. So from the introduction point of view, the stability component is an essential link for the kinetic chain, and it must be optimized prior to targeting a larger group of shoulder joint muscles. Generally, we target the deltoid, pec major for the global movement, and execution of a task which is based for the larger muscles also, as well as for smaller local muscles whose primary role is stabilization, should be addressed first, because optimal stabilization, which allows for optimal mobilization as well as the output for the shoulder joint. And the initial focus should be on any deficit which is discovering during the pre-training examination. And for pattern of motion at the hip, trunk, as well as the shoulder, the actual weakness or an inflexibility of a muscles at those movement pattern needs to be understood. And the specific inflexibility that you can identify in a group of muscles, that must be addressed before going for the kinetic chain rehabilitation protocol. The kinetic chain, as you can see in the left-hand side of the picture, it starts from the leg to the wrist joint. If we talk for the overhead athletic population, when they do the serving activity or when they do the throwing program, all the energy which is transmitted from the lower limb to the upper limb. So if the person has a calf muscle weakness, that is also affect on his performance as well. So optimal athletic function results from the physiological motor pattern activation, which is creating the specific biomechanical motion and position using the intact anatomical structure, which helps for force production. As well as the kinetic chain is a coordinated sequencing of mobilization as well as the stabilization of body segment, as we know about the regional independence. So when the person is into the early cocking phase, it requires a proper trunk extension along with the hip hinge mechanism, followed by trunk flexion in a deceleration phase. If the person doesn't have a proper trunk flexion in a deceleration phase, there is more chances of getting involved, or the person has more chances of injury of UCL ligament. So whenever in a throwers, in an overhead athletic population, you have a complaint of elbow joint, you must check on the opposite side of the gluteus, or you can check to the hip joint rotation as well as the calf muscles. The kinetic chain breakage, the GERD, which is more than 18 degrees, the GERD creates an abnormal scapular kinematics due to the wind-up effect of the arm on the scapula. As the arm is forward flexed, horizontally adducted, and internally rotated in a throwing mechanics, the tight posterior capsule and the muscle pulls the scapula into the protracted phase. That is why it moves into the internal rotation and the anterior tilting of the scapula. And that is the cause of the downward rotation. So when there is a kinetic chain affected, the whole mechanics needs to be changed. The GERD means there is a glenohumeral internal rotation deficit. The abnormal kinematics have been statistically significant in association with the labral injury. So when the person has excessive abduction, external rotation, and limitation of internal rotation, there is a more stress on the glenoid labrum. So it's overhead athlete population, those who are complaining with the labral injury, we must check all the kinetic chain. In the tennis, the alteration of knee flexion has been associated with increasing the stress in the arm also. The right side of the picture, you can see the downward rotation of the scapula. These are the muscles which is overactive in downward rotation, and in upward rotation of the scapula, these are the muscles. So if you want to improve the upward rotation, the picture shows the exercise itself. The movement which you are seeing in this picture that you can implement, that is mimicking to improve the upward rotation of a scapula. It is not all about every time we have to strengthen the rhomboids, we have to strengthen the serratus anterior. Depending on the scapula position in a dynamic as well as the static, we need to train the specific component. The serratus anterior and the lower trapezius must be work together. Both works as a force couple to improve the scapula in upward rotation. If you treat only serratus anterior muscles, you cannot reach to your optimal outcomes. Now the core and the scapula. It works as a bridge. The local and global stabilizers of the trunk works together and it provides the optimal core stability. Scapula works as a bridge to transfer the energy from lower extremity to the upper extremity. So when scapula is not stable, if your shoulder doesn't have enough base, you will not get a proper outcomes. Person may get an injury in the wrist or he may get injury in the elbow as well. The larger global muscles includes the abdominal muscles, erector spinae, and the hip abductors, which are the vital to power generator and the stability of upper extremity function. If you incorporate of a core abdominal as well as the quadratus lumborum, it is also works for the trunk stability. Due to their direct attachment of the spine and the pelvis, they are responsible for more central portion for the core stability. That is why we need to work on the core. It is not all about start doing crunches or a plank, but we have to retrain the external oblique as well as internal oblique for rotation as well. So from the first day, we need to identify what is the patient functional goal. Depending on that, start training the shoulder joint that will help you to improve your functional outcomes. The starting point is we need to create a stable base. The stable base requires a local as well as the global stabilization of the trunk. If we don't have a stable base, we cannot reach to the full flexion. If the scapula is not stable, we cannot reach above 110 degree of shoulder range of motion. You can reach up to 90 degree, yes, that is for sure. But above 90 degree, it requires a stable base. After 90 degree, the scapula starts elevating. There is not optimal amount of external rotation of a glenohumeral. The head of the humerus, you will not get your optimal outcomes. So before reaching the overhead activity, we need to require a stable base of a scapula. So stage of rehabilitation in initial phase, we need to facilitate the trunk position by using the hip movement. As the sir said about the rotator cuff repair, if the athlete comes to your clinic, initially we need to save the rotator cuff repair site. We can't give a too much stretch by doing the movement. We have to discuss with the surgeon regarding the tissue quality, and after that we must start the rotator cuff exercise. But before that, we have to use the hip movement or as well as the trunk movement to facilitate the scapular retraction as well as to promote the scapular depression with the thoracic extension. We need to address the soft tissue inflexibility like pectoralis minor, which is the important muscles to create the downward rotation. If you look at the MRI of the pectoralis minor, it's originated from the coracoid process. It inserted at the coracoid process and originate from your costal surface. So what is happening when the scapula is into the protracted phase, the pectoralis minor become tight and it creates a small area. It creates the small space at the coracoacromial region, and that eventually it converts into the subacromial pain. The closed chain exercise for the glenohumeral joint is a must. We must emphasize on a glenohumeral depression. If we don't get the glenohumeral depression, if we don't work on an infraspinatus, we can't get a full abduction. Many of times I have also encountered with the complaint from our colleagues that I won't get a proper abduction because we don't have enough depression. If we don't have enough depression, we don't have a full forward flexion as well. So the flexibility plays a major role. Avoid external rotation for 3 weeks post-operatively. That needs to be decided with the surgeon only. If surgeon allows us after 3 to 4 weeks, then we can go. Otherwise, stick to the scapula movement, improve from the core itself. Establish a quality scapula motion using the completely trunk and the hip motion. That I will show you in the next slide, how to improve. Improve the flexibility. The posterior capsule tightness, the release, you can go for the sleeper stretch. But on the other side, we need to think about the pain part. By doing the sleeper stretch, if the person is complaining of pain at the AC joint, or if he's complaining at the GT, that indicates that sleeper stretch is not indication for this patient, because by doing this maneuver, the head of the humerus is translating superiorly. So it's jammed up over the roof of the acromion. And that is why the person is developing the pain. So in that scenario, you can go for the cross arm adduction stretch. But in that scenario, we must stop the pain as well. Still, you find the pain, stabilize the humeral head. This is the pectoralis minor stretch, the doorway stretch. According to the John Mostad et al. In 2009, they have very significant outcome for the stretching of the pectoralis minor. By this is the position in that they get the very good outcomes. We have to also work on the hamstring flexibility, because we have to work from the kinetic chain point of view. The flexibility of upper and lower extremity can be the increase via the standard static as well as elastic stretching. For upper limb dominant sports, lower extremity stretching should be targeted. And the pectoralis minor for upper extremity, as I said, and the sleeper stretch that improves the posterior capsule flexibility. We need to focus on a serratus anterior as well as the lower trap. These are the two exercises. This is the push-up plus exercise. In this position, we need to ask the patient to push away from the ground. So it will create the protraction of a scapula. Protraction of a scapula that will enhance the upward rotation of a scapula. And this is the lower trap activation. But before initiating the lower trapezius activation exercise in a standing position, you must require at least 100 degrees of pure glenohumeral range of motion. Otherwise, you will end up with scapular elevation and person will get a pain at the anterior aspect of the shoulder joint. The plank exercise, that is for the core muscles, the oblique activation. What the research says, the comprehensive approach to the non-operative rotator cuff rehabilitation, the rotator cuff strength can be increased as much as 24% when the scapula is stabilized and retracted. So, according to the Sarah Mottram in 2009, she said in her EMG analysis, she said that if you maintain the scapula in its original position, along with that, you perform the lower trapezius exercise as well as rotator cuff muscles activation, you will have a very good outcomes. So we must stabilize the scapula first before initiating any strengthening exercise. So the question is when to start rotator cuff strengthening. The first and important thing is rotator cuff should be intact. And if you have a stable scapula base for the acromion clearance, then and only you can start with the rotator cuff strengthening. As you can see on the right side of the picture, it is abduction external rotation. It requires a proper scapula base along with the humeral head should be in a center of a glenoid fossa. If the person has a rotator cuff insufficiency, and when you go for the abduction external rotation, person may have a adduction of a shoulder joint along with he has an insufficiency of completing the abduction external rotation. On the another scenario, how to differentiate the rotator cuff is insufficient or a scapula, on which component we need to give a proper emphasis. Just give a support, just place 2 fingers below the olecranon process and ask the patient to perform abduction external rotation. If the person doesn't have a pain and he does very efficiently, so it requires a rotator cuff muscles strengthening because you have given the support. So head of the humerus doesn't need to be need to work centrally. If by giving the support, the person is complaining the same, so in that scenario, we have to work on a scapula, improve the scapula base. According to the Crystal et al., this is the kinetic chain influence on upper and lower trapezius muscles activation. These are the different variety of an exercise that you can implement in your patient with the squat as well as along with the lunge pattern. These exercises have a very good impact on upper and lower trapezius activation. And if you break down the throwings activity, that will give you the exercise component like hip hinge, the lunge pattern as well. So if you want to go for the kinetic chain activity, we need to work with the trunk as well as the functional activity. We need to divide each and every pattern of a movement that will guide us regarding the kinetic chain. These are the exercise guideline, the focus on a global muscles, the transverse plane exercise, the sequence of A, B, and C. This all works on the right side of the scapula along with the posterior chain. This all works for the single leg stance. The opposite side gluteus works as a stabilizers. And the scapular depression by hip and trunk extension. This all exercise you can perform the scapular depression once the person is out of the sling. And this exercise you can do till this level, till B, okay, in the sling as well, because we have to facilitate the scapular retraction. In a later stage, you can go for the single leg stance also. In an initial stage, you can go for the single leg stance, but you cannot go for the forward flexion exercise. Now, when it comes to the transition to the endurance phase, once the kinetic chain deficit corrected, focus on improve the power and endurance, you can go for the transition phase. And high repetition that improves the endurance. We have to work for calf, hamstring, quadriceps, and hip abductors. Depending on the athlete's sports, design the program and make the exercise like a fun activity. Otherwise, the athlete will become bored and he has not that much interest to perform the exercise. The improved proprioception and balance. This all exercise has been very well documented by Aaron in 2006. They will give us a very good idea about how to improve the balance as well as the proprioception. These all are the kinetic chain activity. This is the sitting active exercise. The rotation, from the transverse plane to the frontal plane exercise.
Dr. Bhatt, if you can wrap up. Already exceeded. Thank you so much. I believe.
Pardon, ma'am?
I'm
Okay,
saying,
fine.
yeah.
Yeah, fine. Okay. I thought it must be freeze. That's why. So in summary, the upper extremity training program, the components of kinetic chain function should be incorporated. And first of all, identify the flexibility, where the inflexibility is compromised. Find out the potential inhibitors. In the presence of injury or requirement of stability, training regimes should begin with the closed chain exercise. The shoulder joint works in an open chain, but we should start work in the closed chain. If we consider from the fundamental point of view, at the 6 months of age, when the child start getting reach out activity, he is into the transverse plane only. He starts developing the scapula in a closed chain. So from the movement point of view, we should work from the closed chain in a shoulder joint, then eventually move into the open chain exercise. If the person has a stable base in a closed chain, 90-degree shoulder range of motion, then you can expect you can get the open chain exercise with a 60-degree of shoulder range of motion. But there must be a stable scapula. And skeletally mature athlete should focus on both core as well as the scapula stability. Once you find the scapula stable, all groups will benefit from rotator cuff strengthening. So scapula must be stable. Nowadays, people are talking from the rotator cuff related shoulder pain. Before a few years ago, people are talking the scapula is the culprit for a shoulder pain. It's kind of wavy publication is there. So everything is depending on the patient's history point of view as well as the mechanism of injury. If you understand the history as well as the mechanism of injury, that will very much help you where to target and which exercise should be done. Thank you so much. I hope this is very helpful in your clinical settings. Thank you.
Thank you so much, Dr. Jaimin, for such a wide overview of such a huge topic in such a short span of time. But I believe everybody here is sticking on. Thanks everyone to be with us. now without wasting, because many people might be thinking many of the questions might have been answered, but many of the joinees will have some questions with them. So without taking much time, now I invite and introduce Dr. Nidhi Kalra, who's going to be the moderator for question and answer session, which we would continue for not more than 5 or 6 minutes, because we are already surpassed nearly 30 minutes beyond our limit. So Dr. Nidhi Kalra, she's officiating director and head Banarsi Das Chandiwala Institute of Physiotherapy. She's a very energetic professor with many prestigious awards in the field, various publications and books to her credit. And she's with us with a rich experience to moderate this question and answer session. So without taking much time, Dr. Nidhi, over to you. Let's really have it for people. People can put, you can unmute yourself and people can put their questions in chat box. We will take few of them and rest can be answered later. So anybody having any questions, though most of the queries would have been answered, we can put it. Our speakers are very much there with us.
Ma'am, am I audible to you?
Now, yes. Yes, Dr. Nidhi.
Yeah.
Yeah.
I think the speakers were, I mean, they have given the concepts beautifully, and I think they have answered most of the queries, because I'm not able to see any question in the chat box. Because the concept was very well explained from Hemant sir about the subacromial pain to surgeon's perspective, and then to the kinetic chain by Dr. Jamin. But I can see Dr. Balmukund's hand raised.
He has 2 questions in, Dr. Nidhi. Kindly
Yeah,
take-
he has 2 questions in the chat box. Role of LA and or steroid injection.
Dr. Tandon.
Yeah.
Yeah, so please.
Dr. Balmukund, I think I did point it out more than once that there is a huge role of corticosteroid, and my preference is that it should be preferably given ultrasound guided. When I am dealing with anteroinferior sort of adhesive capsulitis, it is better I target that tissue and straight away deliver. At the same time, I like to give a suprascapular nerve block so as to alleviate the pain and help my physio team to quick start their physio protocol. So I like to give the 3 shots at one go.
Thank you very much.
This answers your query, sir.
Yes, sir.
Thank you.
Anybody else?
If I can ask about
Question. He has
Surya
another
Namaskar as
question.
an exercise, global exercise.
Another question on
Yeah, there is one more question. What is the role of medial glenohumeral ligament release? I think, Sir Tandon, sir, this is the question again for you.
Yeah, like I showed, if my presentation was followed, I put 2 arthroscope pictures of a normal joint and a significant adhesive capsulitis joint, and you can see that that is the area where there is the maximum amount of synovitis as well as contraction. The rotator interval and the MGHL are significantly contracted, and the patient and the physio team has been struggling for a time. Our steroids did not work, or if they were given blindly, they were only given in the subacromial area. So the steroid will not reach there. So if this patient now needs surgical release, I have to do the MGHL and sometimes the anterior limb of the inferior glenohumeral also, if it is very much tight. I did mention that if my scope, I can't swipe through, that means there is a significant contraction happening there.
Yeah. Thank you, sir.
I have a quick question for Jamin, if I may.
Sir.
Surya Namaskar or sun salutations are very, very common exercises in India, and they are spreading all over the world because of Yoga Day now. any ideas about how it can be used or should it be used or not in any shoulder pains,
Yes,
especially as a global exercise?
yes, you can use the Surya Namaskar, but the thing is that there should not be a pain in the shoulder joint. You can use the pose like the triangle where the person is going down and then he comes back. That is the very good exercise to improve the upward rotation, as well as it works as a close chain exercise for the scapula. So you can use that pose in your patient, but apart from that, there should not be a pain. That is my first priority.
Yeah, I hope that that answers the question well, because you had already explained about the close kinetic exercises role in scapular stabilization.
Yes, yes.
Yeah.
Thank
So I
you
hope,
very
sir,
much. Thank you.
yeah, welcome.
Can I just add on to this discussion, Nidhi?
Sir, please.
Regarding pain, some of the latest evidence points out that if it is a pure overuse related pain, rotator cuff origin or supraspinatus, a pain level from, let's say, on a scale of 10, 0 to 3 is quite acceptable, because low loads actually promotes tendon healing, and this is well established. So it is quite okay for some patients, and I'm again emphasizing some patients where we are close to saying that yes, it is an overuse tendon related injury, more like tendinopathy. In those cases, it is well established that some pain is acceptable under training, as long as we don't irritate the shoulder. Pain does not persist for a longer time, let's say about 30 to 60 minutes post exercise. It is quite acceptable and promotes healing actually.
Okay.
Thank you, sir. We have another question. I think we'll that should be the last, Siva ma'am.
Yes, that should be
Yes.
the last question. Itself.
Yes. So can we start early retractor strengthening with stimulation post-operatively after release, medial glenohumeral ligament release, to gain maximum effect of the surgery? And then, sir.
No, if it is a release which has been done to gain movement, I see no contradiction to do this. Probably Hemant and Jaman can also pitch in.
Yeah, I think electrical stimulation can be used, and but it is used only in patients where you observe that activation is really getting difficult for the patient. So if a patient has active control over retraction, FES or functional electrical stimulation has limited role. It has a role where it is really has troubles from getting activated to an active contraction. Because if you have an active contraction, you can use simple strengthening exercise. That should be more than enough actually.
Yes, and I would suggest that if we want to start early retraction, you can use the trunk approach, like forward flexion to the extension. So the exercise which I showed in the transverse plane, that helps for the activating the retraction. Sometimes we find out it is very difficult for the patient to do the retraction. They don't understand what is retraction, how to perform the retraction. So in that scenario, if we are using the trunk and hip approach, that will help us for the early initiation of the retraction exercise.
At times, initially, because of the pain so the patient is unable to really sense
Yes.
the proper retraction. So maybe working to some extent on pain relief can be a component. And as you said, of course, working on trunk and hip would be the right way. So thank you so much, everyone. I would really like to express my appreciation to all the speakers and our moderator for question and answer session for their such a valuable contribution on a weekend for today's session, and sharing their very rich experience and knowledge on this topic of non-traumatic shoulder pain. I would like to express my gratitude towards Dr. Anupam Sibal, the Group Medical Director of Apollo Hospitals and President GAPIO, for his constant support and vision for sharing such platform, which would help us to break the glass ceiling and provide maybe superlative healthcare services. I believe who all have joined us today will definitely will have certain very clear take-home messages and would have clarified into their concepts. People working in tertiary care do get such things from the surgeons and other colleagues very often, but people working in clinics, I believe, very correctly as put by you, Dr. Hemant, that irrespective that there are so much of clinical tests, we have to be very, very clear, categorically knowing that what anatomical structure we are on. And from you, I really felt that that is a very strong message, that strengthening itself is a big deal and we must look into that. And with all our eminent speakers today, I would really like to thank everyone from bottom of my heart. And lastly, I would like to express my deepest gratitude to all the attendees on a weekend evening. They are still staying with us. We are really overseed the time, more than half of it. And to make this event such a successful one. And my thanks to the hospital's primary team, which is the IT team, and from GAPIO, the members who have their priceless contribution in running this event so smoothly. So I hope all of us who are along here, we have a wonderful evening ahead. And for you, Dr. Hemant, maybe for us it is later evening, for you it is early evening. Thanks everybody to make it such a powerful, power-packed show. To all the attendees, to all the speakers, moderator, I am really grateful and feeling overwhelmed. I believe there are a lot of concepts which people will agree with me, gets clarified when we really talk of what is latest in the field, what is, and we try to make it a very wholesome stuff in 1 hour, which seemed for more than 40 minutes. And thanks everyone once again. And I hope we meet again soon. We do it quarterly, but the kind of response we have, I believe we can make it little more early, and this would be something really nice. Thanks everybody. Good night and good evening to
Thank
the
you.
people, or early morning to the people who are there. Thank you very, very much for your expertise and time. And
Thank you, ma'am. Thank
let's
you.
have a wonderful evening ahead.
Thank you, Dr. Seema.
Thank you, buddy.
Yes.
Thanks, Dr. Gaurav.
Thanks everybody. Thanks, Nidhi.
Thanks, sir.
Thank you, sir.
And,
Good to
of
see you
course-
after such a long time.
Yeah, thanks a
And
lot.
Of course, our Dr. Bhavna, who just joined in and shared her vast experience of 40 years with us, how the things have changed. So it's really beautifully taken. Thank you, everybody, for accepting my invitation and being a part of it. Thanks, everyone.
Thank you.
Good night.
Thank you.
Thank you. Take care.
Thank you.
Bye.